Thank you for joining us for conversations and updates in gastric and GE junction cancer, practice-changing expert insights to improve outcomes. This activity is titled Practice-Changing Updates in First-Line Treatment of HER2-Positive Disease in Systemic Treatments specifically. My name is Dr. Yelena Janjigian. I'm a medical oncologist and chief of GI Oncology service here at Memorial Sloan Kettering Cancer Center in New York City. It's a pleasure to have my colleagues, Dr. Shah and Dr. Klempner, join us. And we will start by talking about the landscape for HER2-positive disease. The treatment for HER2-positive disease is evolving rapidly. It's a very hot topic of discussion. We've known over a decade, probably close to 12 years, that HER2-positive disease is a targetable problem in upper GI tumors in the esophagus and gastric cancer. Depending on where in the GE junction you look, whether or not it's distal esophagus, GE junction, or distal gastric cancer, the rate of HER2 positivity can vary. It's probably the highest in a distal esophagus and GE junction. So in the United States, where those tumors are much more prevalent, we can see up to 30% of patients have tumors that overexpress HER2 or have HER2 gene amplification. So the TOGA study was actually a study primarily accrued patients ex-US, outside of the United States. And those patients were with first-line disease that were either FISH positive, which were even including IHC negative patients, or IHC 2 plus, FISH positive, and IHC 3 plus patients were treated with chemotherapy plus minus trastuzumab. And this was the first validated HER2-directed strategy in this clinic. And what's interesting is that the greatest benefit that we saw is in patients that you and I would consider clinically HER2 positive now, which is IHC 3 plus or IHC 2 plus and FISH positive patients. And what the TOGA analysis suggested is that tumors that were HER2 IHC 0, FISH positive, were not as HER2 driven. So this was an important, exciting breakthrough for our patients. Manish, I remember still talking to you about it. And so what are your thoughts about, HER2, sort of level of HER2, and how do you think about it when you see, for example, a FISH positive patients with perhaps with lower or focal HER2 immunohistochemistry? Do you approach those patients differently?
Yeah, no, so I remember our discussions as well. I mean, this was really exciting and practice changing. I mean, we were in an era where there was targeted therapy for colon cancer, lung cancer, and we had nothing in gastric until this study. And I have to be honest, my wife had the similar reaction that Dr. Klempner did. It was like 2 months, and she's like, we have to do that. So with that in mind, I think that you're absolutely right that the Europeans probably got it right, that the HER2 high tumors, the ones that are IHC 2 plus or 3 plus and FISH positive, I should say IHC 2 plus FISH positive or IHC 3 plus, that, the Kaplan-Meier curve for that group, the median survival was 16 months versus, I think 12 or so, something like that. So that I think that really changed the landscape. And for the HER2 low FISH positive tumors, we've always hoped that there would be a drug that might be effective there. But in that population, I tend not to use trastuzumab. I'm hoping that we can learn something from your study, Keynote 811, or whether or not that's possible. But at least for trastuzumab alone, I don't do that.
With chemotherapy, absolutely. Sam, tell me a little bit about, so we know that HER2 is important, and in breast cancer, just going after HER2 in a better way with dual HER2 inhibitors or, more complete HER2 inhibition with antibody and a TKI, for example, has really paid off, right? All of the lapatinib trastuzumab studies, pertuzumab trastuzumab studies were positive. Why do you think it was not a good strategy in gastric? What is different about gastric than compared to breast?
Yeah, I mean, we're still trying to answer this question, but it is quite different. And if you want, I can do my best impression of you and cover the rationale for 811. But yeah, so heterogeneity for the first part. We learned pretty early on that you can biopsy primary gastric cancer and stain HER2 in multiple regions of the biopsy. And if you were to base your result on only one of those regions, you'd get different results. So one area would be called HER2 positive, another would be called HER2 negative. We also know that after trastuzumab-based therapies, there's tumors change. There is perhaps either a clonal outgrowth of HER2 negative population, or some people have termed this loss of HER2. But this has been a lesson in biomarker development. Many of the other trials you mentioned combining dual antibody HER2, HER3 strategies, or HER2 TKI, or even the early TDM1 were arguably plagued by biomarker selection problems that we have learned over the years. And I think that's probably the simplest message. I think we're learning a lot about where we can fill these gaps. In the subgroup analyses that I've seen, it looks like NGS-detected amplification may actually be the best associator with outcomes. Certainly, this is opportunities to fill gaps with, ctDNA to complement tissue. What can we learn about these populations? So it's actually quite a fun time to be doing work in this space because we are getting better. But the heterogeneity is probably the primary difference, and it may stem from the tumorigenesis mechanisms. These tumors are essentially all chromosomally unstable, the HER2, and HER2 is a relatively later event in that process, and so that's probably partly the explanation for the heterogeneity, is that by the time the structural instability has developed, there's sort of a polyclonal tumor population, and not everything is going to be HER2 positive.
That's exactly right. And unlike breast, where chromosomal instability in HER2 positive gastric or even G junction, more so tumors, is such a dynamic process over time. Every time the chromosome or the cell divides, you just gain more and more aneuploidy and errors. And you gain other problems such as KRAS, PI3 kinase alterations, MET. So it's almost impossible to go after HER2 alone and be successful. To Manish's point, I think having this bystander effect and being able to go after HER2, even if it's at a lower level, and then have the rest of the cells be killed by perhaps cytotoxic therapy or other immune-related cell death, really has been our strategy to try to bring more effective treatments to first-line setting. I'll speak about Keynote 811 in a sec, but also, bringing some of these antibody drug conjugates that we have in later lines early on while the patient is still fit and while the disease heterogeneity has not taken off completely in a different non-HER2 related, a tangent, to be able to have that bystander effect is critical. So Keynote 811, that was the reason why, it was clear to me trying to target HER2 in second or third line setting was, I've done enough negative studies to understand that it was going to be a big challenge. And going after HER2 just specifically with other dual inhibitors have not panned out. In HER2 positive tumors, a lot of the effect is actually with trastuzumab is through the ADCC effect and cytotoxic death from in that way. And also we see that PD-L1 overexpression goes up over time with trastuzumab therapy as a way, again, to become more resistant to trastuzumab therapy in those tumors. And so that was the rationale for dual anti-PD-1, anti-HER2 blockade that we tested in HER2 positive tumors, irrespective of PD-L1 in phase 2 setting. Just to give you a benchmark flavor for this, we expected, the 47% overall response rate that was seen in large phase 3. We were with the TOGA, with chemo plus TRAS, we were hoping to improve somewhat on it, and we saw a 91% overall response rate in phase 2 setting. And then you always expect dilution effect, right, from phase 2 to phase 3. And you wonder how much of that effect you'll see in a large randomized phase 3 placebo-controlled study. And what we saw, interestingly, a 74% overall response rate with addition of pembrolizumab, trastuzumab, and chemotherapy, which was a nice delta in overall response rate. 23% is more robust change difference than we saw, for example, with Checkmate 649 in HER2 negative space, which was 15% improvement with chemotherapy and immunotherapy addition. It raises a lot of interesting questions.
Yeah, so I think I just wanted to emphasize one thing, which was already touched upon, and another way to say what was discussed is that in breast cancer, HER2 is a clonal event, and so targeting HER2 in breast cancer, trastuzumab, works very well, and in fact, the practice is to continue trastuzumab beyond progression. But that was examined in gastric cancer and it was a negative study, and because of that difference between clonal event in breast cancer and subclonal in gastric and GE junction, the TDM1 and pertuzumab is actually negative when it was tested in gastric cancer in the first and second line space, and lapatinib was negative in the first and second line space as well. So I think here, understanding the science and the biology probably did make a difference, and I think. It's important to mention, we just touched upon it, but a new class of drugs, the drug antibody conjugates, or the ADCs, and HER2 or trastuzumab, trastuzumab deruxtecan, which is a drug antibody conjugate, it has a 50% response rate, probably 40% in the second or third line setting, and I think the advantage of that is that HER2 is a valid target, but we need other strategies or other, ancillary mechanisms to kill the tumor, like the addition of a payload like the deruxtecan or immunotherapy to try to augment the efficacy and take advantage of that targeting. So I think this is really an important aspect for a lot of people that you're used to breast cancer continuing trastuzumab. You can't do that. You have to change the drug or add different drugs in gastric and GE junction tumors.
It's a great, all great points, and we have a separate segment to talk about some of these ADCs. But suffice it to say, we are working on bringing antibody drug conjugates to first line setting in gastric HER2 positive disease. Destiny Gastric 03 is a trial that's looking at antibody drug conjugate trastuzumab deruxtecan in combination with pembrolizumab and capecitabine in first line setting. Sam, do you make a sort of judgment on what to do for HER2 positive disease based on any other biomarkers besides HER2, such as PD-L1, or if you happen to have a ctDNA that shows a MYC amplification or EGFR amplification in the same patient?
Yeah, HER2 is pretty cool tumors. I think we did a very small RNA-seq experiment just to look at the immune contexture of HER2 tumors, and intrinsically they do seem to have upregulation of a lot of pro-inflammatory pathways, things that you would be like the right background to add on PD-1, even though not all of them are PD-L1 positive, although majority seem to be. And even on treatment samples after trastuzumab seems to upregulate these pathways even further. So I think it's a very fertile ground for other immunomodulators. We, at this time in practice, a newly diagnosed frontline HER2 positive patient by standard methods, so IHC 2+ FISH positive or 3+, we adopt the KEYNOTE-811 regimen broadly. I think the subset of PD-L1 negative tumors is provocative, but far too small and post hoc to really draw any conclusions at this point. We're interested in the genomic context, as you implied and suggested. MAP kinase pathway alterations seem to be associated with a lesser duration of benefit. But these are again small exploratory analyses. We saw that from the Panthera trial, which was recently published. And that's been a pretty consistent feature across publications. But although we're interested in that, we don't routinely incorporate it in practice yet.
Right. Well, thank you again for joining me for this segment on systemic treatment of advanced gastric GE junction cancer and HER2 positive disease. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, or ACPE credit, access supplemental slides, and other topics and segments in case scenarios. Thank you.